Thank you to everybody for being here this morning. I don't know if it's me or just time is passing really fast. It seems like about a minute since we were last here. But thank you for joining us for the April meeting. I want to begin, as we always do, just talking a little bit about what we have seen in our county over the past month. Fortunately, it continues to be good news, recognizing, of course, that even one loss of life is too many. We continue to see some real progress here. In the period of time, the last 4 months, comparing this year to last year, we have seen almost a 27% reduction in fatal opioid overdoses. And that is really attributable to the work of everyone on this call. It is different from what we are seeing across the state, and I think it really is this collaboration, this coordination of work that is making an enormous difference here. What we are continuing to see, unfortunately, is while those numbers are declining pretty dramatically, the number of intentional deaths from opioids is increased well over double in that same 4-month period. And remember, we are very conservative in terms of calling something a death by suicide. It is really only when it is absolutely clear. There's a note. Somebody has said something just before doing something. So that number, as startling as it is, that it has more than doubled, is probably even greater, because there are clearly things that we don't count that probably fall into that category. So it just reminds us of how much more work we continue to do. And today, I'm really delighted to be looking at additional supports, both for people still struggling with the disease and for people trying to maintain sobriety. And for those of you who might not have seen it, just in the last 10 days or so, Mass General Brigham announced that they were implementing a very important new policy where, contrary to what they had done in the past, they would no longer be reporting suspected abuse or neglect to the Department of Children and Families solely because a child was born showing an exposure to drugs. And there's a very good article by Matt Stout in the Boston Globe on April 2nd. I'm sure we can put that in the chat for people. BUR also did a very similar article. And pursuant to that new policy, doctors, nurses, other medical staff at the hospital, the Brigham, will now only file that 51A, that notice of abuse, suspected abuse and neglect, when there is reasonable cause to believe that a child is suffering or is in imminent risk of suffering physical or emotional injury. So that just showing exposure to drugs, there will have to be some other protective concern before they will file. And also, the Brigham, in conjunction with that policy, will now require written consent for toxicology testing for a mother or infant in most cases. And really leading the charge in that way was Boston Medical Center, who made similar changes to their practice in May of 2021. And I'm really delighted today to be joined by doctors from Boston Medical Center to talk about that. And in conjunction with that change, where we're going about that reporting, I want to just mention 2 important pieces of legislation. There is a state bill that would amend the reporting requirements in Massachusetts. That's pending in the legislature right now. And that is very similar to the policy I just talked about. It says that simply evidence of prenatal substance exposure, that alone is not sufficient for the filing of 51A. There is also a federal bill called the Safe in Recovery Act, which is being supported by Senator Markey. And that would block states from requiring healthcare professionals to notify child care professionals if the mother is taking a drug, and the language is in accordance with the recommendations of a prescribing practitioner. So someone who, as part of their recovery, is on medication that's been prescribed by their practitioner, the fact that that is showing up in testing, that would bar states from making that as a report. We've all seen those circumstances where people who are in recovery are pregnant or delivering their child, and maybe they stop taking their medication because they're afraid it will show up at the hospital, and that will lead to the filing of a 51A. That bill is pending in Congress, similar to what we've talked about the requirements. It would prevent states from requiring a tox screen without the consent, clear and informed consent of a mother by the medical professionals. So we're continuing to work on that. We're advancing support for those. I'm happy to hear from people on this call, now or later, about some of those issues. But I want to turn to our presenters today. And our first presenter is somebody who's been a good friend to us in doing this work, Dr. Sarah Begley, who is the medical director of Boston Medical Center's Center for Addiction Treatment for adolescents and young adults who use substances. And the catch name is Catalyst. And we'll also be joined by Dr. Miriam Coromoni, the medical director of the Boston Medical Center's Graken Center for Addiction. And beginning with Dr. Begley, she is a primary care physician at the medical center. And she's also an associate professor of adolescent medicine and pediatrics at the BU School of Medicine. Dr. Begley specializes in treatment of adolescents and young adults for their substance use disorder. Her research interests focus on the treatment of those disorders with a particular emphasis on the involvement of the family. And we've heard before about Dr. Begley's center and the work they're really doing to include a family in a young person's recovery. So, Doctor, I'm really happy to have you back with us today, and thank you. I'll turn it over to you.
Awesome. Thank you so much for having me. I really, really appreciate it. I am, and I live in Newton, and I have 3 kids. And so it's just like, we all have multiple identities, right? Or things and so I'm here because this is my career path or my professional work, but just sort of also think about it as like a community member and a parent. And, so I think, that part is important to share as well. I'm going to share my slides in a second. I'm going to talk a little bit about overdose first, and sort of about the impact of overdose on youth and in youth in Massachusetts, and sort of opportunities that I think we have to improve the overdose prevention that youth have access to in Massachusetts. And then we'll talk a little bit about the Catalyst program and sort of what they do, but really hoping to leave a few minutes for questions. But I'll leave my email address too, so that if folks have other things that they want to talk about afterwards, I'm always eager to keep talking about this for sure. So let me do this. All right. So, I think oftentimes, when we think about overdose, I don't know why it's blurry at the bottom. When we talk about overdose, we don't necessarily think about young people. Like, sometimes we might think about younger children who have been impacted by the loss of like their parents or grandparents or guardians, but just want to sort of call your attention to the fact that the youth are absolutely impacted by the overdose crisis. Like, overdose is actually like the 3rd leading cause of death among children and adolescents in the United States, which is pretty remarkable. And then when you look at what's going on in Massachusetts, it's hard to read, so you're going to have to believe me. When we look at all deaths among 15 to 24-year-olds, in 2022, there were 427 deaths. And of those, 102, so like almost a quarter, were opioid-related overdose deaths. And so, I am sitting here, I imagine many of you, like, we are brought to this work because we take care of individuals and families, and we work in communities where, like, each of these deaths, these numbers, like, represent like a kid and a family and a community that is suffering and has been devastated by that death. And these are also preventable deaths. And so I just sort of how do we think about, like, what is the call to action to sort of make sure that we are preventing these deaths going forward? This is another way to look at it, which also sort of, I find sobering, and is also an opportunity for things to be better. This is, I'm going to walk you through what the slide shows though. So this is looking at what percent of deaths are related to drugs among all deaths. And so Massachusetts is number 5. And so nationally. So what that means is that we have a very high proportion of like all the deaths that happen among 15 to 19-year-olds. We have the 5th highest group who have died from a drug-related cause. And so like this is not good. You do not want to be like near the top, right? Like this is again, so this is really an opportunity. These are national data. Like this is again, it's sort of an opportunity for us to be thinking, what are we doing to sort of think about youth overdose prevention, and what can we maybe be doing better in a more systematic way? And so want to suggest this idea of sort of how do we start having like universal or more conversations about overdose prevention with youth and with families and in communities, and how do we do it in a way where I think is really important. Some of you may be in the more in the prevention space, where we continue to advocate and elevate primary prevention and sort of really honor the incredible work I think that has been done around in primary prevention, because we see actually very low rates of substance use, like rates of substance use among adolescents has been going down. Like that is awesome and we should celebrate it. And as we all know, the drug supply has really changed and is a lot more dangerous. And so even first time use can lead to an overdose. And so how do we say no use is safest? And let's talk about that. And then if you're going to use, or you're in situations where your friends are maybe using, how do I make sure that you have the information that you need to make the safest decisions? And then how to respond to an overdose too, because if that happens, I'm sure, I don't know, I've had a lot of conversations with teens over the years, and oftentimes like their questions are like, when do I call for help? How do I know if my friend, like they're so worried about their friends and their peers. So how do we make sure they have that information so that they can also be taking care of their friends? So one opportunity is thinking about access to naloxone in schools. So this is like a snapshot, a little picture of a letter that was shared last fall from the U.S. Secretary of Education and the director of the Office of National Drug Control Policy, and came out through the White House, sort of saying that it's critical that youth and school personnel can access naloxone on school grounds during and after school, and was really advocating for us thinking more about sort of access in school and teaching kids in school about Narcan, which is exciting. I think we have a ways to go. This is sort of a picture nationally of what's going on where schools are allowed to have naloxone. This is from last fall. I don't think much has changed. Oops, I went ahead. But actually, in Massachusetts, like we actually are, I think, have some opportunities for growth here in terms of making sure that there's like a more standardized way to ensure that youth have access to evidence-based, like accurate information about overdose prevention, and then also to naloxone. The other place that I often think about, and I'm going to sort of transition talking a little bit about Catalyst, is thinking about healthcare settings, so primary care practices and family medicine practices and emergency departments, and really trying to think about other spaces where we can open the door to having conversations with teens and their families about reducing the harms related to drug use. And so this was just like a paper that we wrote that just came out this month though, and it was a big deal because it was the first time that sort of we were able to say as pediatricians that we think that we should be talking to all kids about overdose prevention, not just kids who sort of screen positive because they've used substances or they've used cannabis or they've tried alcohol, but really saying that all kids who walk into a pediatric primary care office should be having conversations about overdose prevention and how to use naloxone, and that we should be having those conversations with families as well. And so that's sort of where we are, and that's really what we're advocating for. And just want to highlight that, and maybe some of you even know her, the middle author here is a mother who lost her teenage daughter to overdose. And has really become an incredible champion, advocate, and collaborator sort of on this work, trying to say that we really need to be doing a better job of talking about this with kids. These are just a couple of, I think this is just to emphasize that a lot of overdose education happens in adult settings, but we don't really have the same opportunities for youth to learn about fentanyl and how to stay safer. But that, we know that even though drug use has gone down overall, that there is fentanyl in counterfeit pills and stimulants and other substances. And so oftentimes youth might not know that they are using opioids or using fentanyl or at risk for overdose. And so that is why it's just so critically important that we're having these conversations with them. There are no age restrictions on naloxone, and it is something that we can be prescribing. We give it out I'll talk a little bit about what we do in our clinic, but we give it out in our clinic. And then some of you, I imagine many of you are familiar with the Good Samaritan law, but it also applies to youth, which is a question we often get from our patients, just sort of, being concerned or having questions about whether or not they're protected or are they going to get in trouble. That's what they're asking. They're not necessarily asking about Good Sam. So, I think one of the ways that we've been fortunate at BMC to respond to thinking about, drug use more generally and certainly how to prevent overdose is to be able to develop lots of sort of innovative programs sort of across the lifespan. And so Catalyst is our program for adolescents and young adults. I've actually recently stepped down as the medical director, but still see patients. I'm seeing patients this afternoon in Catalyst, and it's this multidisciplinary team. We've been around since 2016, where we provide wraparound care for youth through about age 25 or so. We have social workers and nursing and pediatrics and psychiatry and a program manager. And we're based in primary care, although not all of our patients have pediatric primary care with us. And we really take a harm reduction approach and try to meet people where we are, or meet patients and families where they are, and just sort of accept that there is oftentimes a lot of ambivalence and sometimes return to use, and different agendas or objectives that people have. And we just want to make sure that, engagement, we think is one of the, maybe the most important thing that we can try to be working on. Because without kids showing up and talking to us, there's just like not much we can actually do. And so really try to, work hard and create an environment where that is safe for kids. But I'm going to stop and sort of answer questions that you might have either about overdose prevention or about the services at Catalyst, or sort of even just more general, questions about sort of youth substance use care and best practices.
All right, questions, comments? We have so many people, I can't see everybody on my screen, so people want to raise their hand or just speak out a question. I'll keep an eye on the chat. Sabina.
Yes, good morning. Dr. Bagley, thank you so much. I think that paper that was written is just phenomenal. It's long awaiting. I think it's been a long time, sort of, we've all known that it's been needed. And I think to sort of talk about the elephant in the room and educate these things, they're going to go to parties. Even if your kid is a really good kid, they go to parties, they end up in situations, whether it's in elementary school, high school, or in college even. And the sooner we teach them what that looks like to see somebody who's OD'd, so they're not terrified, and how they can help them, I think this is huge. I take my hat off to you and your colleagues. Thank you for that.
Well, thank you for that. And I think it's really important. Like, these are hard conversations. Like, I just talked about it in this very sort of matter of fact, but like, I have a 5-year-old, an 8-year-old, and an 11-year-old, and I like trying to figure out how to navigate conversations at these different ages. Like, this is not easy. And so I don't want to make it seem like it's not easy. And you said something so important. Like, they live in the world. And so part of our job is like the grown-ups is to like have hard and sometimes uncomfortable conversations and to like figure out how to do that so that they have access to the information so that they can be as safe as possible. And so not that it's easy. I was like talking to folks on our team at some point recently about just like how much risk we hold and like how uncomfortable and hard it is. So that is part of the work, but
I think the other thing you mentioned is I think the other thing you mentioned that's really important is kids are scared at any age when they're in the presence of it and what their sort of liability is. Am I going to get in trouble too? Should I just run and tell mom and dad when I get home? And then there's the guilt about if the kid sort of doesn't survive this or so. So I think all this information is very important for them to know what's the best course of action. We had this young girl who was in an adjoining town. I live in Needham, and she was at a party and there was some drugs and alcohol. I don't remember the story exactly, but all the children fled and they ran, and she ran in the backyard and didn't realize that there was a cliff. She jumped over that and actually, died, because it wasn't like a really deep cliff, but she hit her head and, she had a hemorrhage. So kids are afraid and they run because they don't know how they might be implicated, even though they haven't done anything. So that's important too, I think.
Yeah, no, I think it raises just sort of like, what are the different components of sort of overdose education, for teens, and certainly thinking about that, I think is like an important aspect to include. And I love what Brittany said about sort of open conversations and creating exit plans. I think oftentimes I've sort of been thinking recently about how sometimes even these conversations, like we talk about naloxone and overdose prevention and give out naloxone, we give out fentanyl test strips in our program too. And like, I hope that if they need the Narcan, they'll use it, or if they need a fentanyl test strip, that they use it. But I also sort of have come to believe, I don't have data. I'm a scientist, so like I wish I had more data about this, but like I don't have data, but I have like my gut is, I guess, telling me that it opens those conversations, that it's like it allows this like safer space to have conversations, or maybe we get some credibility. I don't know what, and that's the part that feels like magic. Like that's the thing that we're sort of trying to do. And so I think, the other thing, some of the research that I do is more with young people, or like working with young people. And I think the more we can think about how to like involve and collaborate with them, have them be involved in developing curricula, or teaching near peers sort of about overdose prevention, I think also could be like really, really potent as well.
Mary, did you have a question?
I did, yeah. Hi, I'm Mary Haas from the city of Newton. Sarah, I think you might be on our coalition. Is that right?
I am.
Okay, that's what I thought. I was
Yeah.
like, I recognize your name. I'm a little bit new to Newton. I also live here. I've really appreciated your presentation. I think you know that we're moving forward with putting sandboxes in public buildings and in the schools. So I was like taking pictures of your data about the schools. And so I was wondering if you had any more resources, since we're going to be going to speak with them very shortly. And we're aiming to get these nalox boxes in locations that aren't just faculty facing, but and go from elementary school all the way up through high school. And I can anticipate some resistance. We're hoping not to have too much. We have, the school nurses are on our side. They're in our department with us. So that's really beneficial. But I was just wondering if you had any other data around kind of some of the concerns that might come up from administration around, I don't know, exposure, like why we would need it in elementary school, for example.
Schools.
That's
Yeah. Why don't I send you some stuff, Mary, if that's okay? Like I
That'd
can
be
sort of
great.
send you some examples even of what's been happening in other, not necessarily Massachusetts, but in other states. They're sort of like moving forward with some of this. And I will also tell you, as the parent role, I've talked to like our neighbors and stuff, and I have a kid who's going to be transitioning to middle school, is going to go to Brown Middle School, and then my other kids are in elementary school, and like the parents are, or like the parents that I'm around are very enthusiastic about this. So I think also there may be a way to like think about engaging with some families or parents who would help back you, back you up as well and support.
Yeah, my hope is that there's no resistance, but I want to be prepared for
I think it's always better
the inevitability that there might be some. So
Well,
thank
the
you.
other thing that we have seen too is the importance of having it available because of the other things that happen in schools. So we've had lots of incidents where there's like a dance tournament or a game or whatever. So you've got a lot of people. And one of the things we discovered when we first started making naloxone available to the schools, we had some schools that seemed to be going through a whole lot. And I was like, what's happening here? And we forget about this part, though, particularly in certain parts of our county where the medical facility might be a pretty far drive. People think school nurse. So they would be in a car with somebody who was experiencing an overdose. There's a school everywhere, right? So we had lots of people kind of pulling up to the front door of the school in need of help. And I think that's the community piece of there's people who look to those places. They see that flag, they think there's a school nurse in there. And, you know, I have places where it's 20 miles to the next hospital, and that's where they're going.
Yeah. That's incredible. That makes so much sense. Thanks for, that.
Other questions, comments?
Dr. Bagley, I have a quick question.
Yeah.
Thank you for your presentation. Going back to the numbers that you shared at the beginning, can you, I tried to write it down for 2022, for the ages between 15 and 24, you said there were how many deaths?
Oh, there are 427 overall deaths, like in that age group, and then 102 of them were opioid related overdose
And
deaths.
do you know, do the numbers break down, so 15 to 24, do you know if it was like, you know,
Like
more
how
than
many?
20?
Yeah. So the way that DPH age stratifies things, that's the age group. So we've been trying to look at the CDC data because you can look more at that like 15 to 18 or 15 to 19. So that's why I showed the second. I can share the graphs with you, but we are, you know, one thing, I don't know if this is anyway, one thing I've been thinking about or have wondered about is like the idea of like thinking about more. I know that the idea of like opioid reviews or case reviews among adults has been something folks have talked about. I've sort of thought a lot about child death reviews and sort of how we could do a similar thing for like opioids or overdose specific for teens, because I do think some of the risk factors are different, and I think we need more information so that we can do a better job at prevention. And so I think the more we can be sort of learning from what, you know, what's actually happening in our state among sort of teenagers, the more, you know, the more effective our interventions or responses can be.
That is something we could pretty easily organize because we lead those child fatality reviews.
Yeah.
So, and what we tend to do is we cluster kids who appear to die from the same causes. So if over 6-month period, we have 3 drownings, we'll do a day when we do the drowning situations and try to look at what that is. We could easily make one of those clusters be overdose.
I'd be very interested in help. Like I offer,
Right. Yeah, we can. That's definitely something we can do.
Okay.
That's an easy fix for us. Anything else? Well, Doctor, as always, thank you so much. Thank you for the work and for being with us and sharing that with us.
Yeah, thank you all. I'm going to sign off, but I'm going to throw my email in the chat. And if folks have, please be in touch and I'll share the slides. And thank you. Thank you all so much for the time that you give to this and the work you're doing.
Thank you.
Appreciate it. Okay.
Thank you. All right, joining us now is Dr. Miriam Komaromi, who is a physician and the medical director of Boston Medical Center's Graken Center for Addiction. And she is board certified in internal medicine and addiction medicine. And her work leading the center is really focused on enhancing all of the medical center's work on addiction, which is a broad project. It includes their clinical programs, education, research, policy advocacy, and really taking this work and bringing it to a national conversation. She received her medical training at the University of California at San Francisco and later served there in their Department of Medicine. She was a Robert Wood Johnson Clinical Scholar at the University of California, San Francisco Stanford program. And prior to coming to join us here in Boston in 2019, Doctor was an associate director in the University of New Mexico's ECHO Institute. And ECHO stands for Project Extension for Community Healthcare Outcomes. And she developed and led the medical education program focused on the treatment of substance use disorder. So, Doctor, thank you for being with us this morning.
Thank you so much, DA Ryan. I am on by picture because my camera broke this morning, and I've been working with IT for the past 45 minutes, and they say it's a goner, and they're going to have to replace it. So
no worries at all. We're happy to
see my picture, and I'll share slides. Great. So thank you so much for inviting me to talk with you today. I'm happy to tell you a little bit about the work that we do at the Graken Center for Addiction at Boston Medical Center, and also to talk a bit about some things that we're doing on more of a statewide level, so that we can kind of be in dialogue with you. And I really wanted to start by thanking the excellent work that you all are doing. Uh-oh, this is saying Zoom quit unexpectedly.
You're good. We
Can
have
you
your
guys,
first
you
slide
can
there.
hear me? Okay,
Yeah,
okay.
I can hear you and we have your first
All
slide.
right, it's one of those days.
Yeah, I get it.
Yeah. So I put my contact information here on the slide. If I'd be happy to talk more afterward, and also if there are ways that I can be helpful, please reach out and let me know. BMC's Graken Center for Addiction started 5 years ago, a little over 5 years ago now, with a large philanthropic gift from John and Eileen Graken. And that produced an endowment that allows us to run the center year after year. And it's unusual in that the Grakens chose to name the center after themselves, because typically when people give large donations related to substance use disorder, they don't choose to be named because of the stigma associated with substance use disorder. And it was really wonderful that Eileen Graken, who kind of spearheaded this, was willing to be named and to acknowledge that she herself has a substance use disorder and has struggled. So somebody with lived experience who has really played a big role in helping BMC at Boston University do our work around substance use disorder treatment. So let's see. So since you can't see me, I put a picture of me on here so you know who's talking to you. As DA Ryan said, I'm a professor at Boston University, and I lead the Graken Center for Addiction at BMC. The Graken Center within Boston Medical Center is composed of a large number of our faculty. So as you probably know, BMC has specialized in treatment of substance use disorder for many, many years, both in terms of clinical programs and also the research that we do. We produce more than 100 papers a year in the scientific literature focused on treatment of substance use disorder and prevention. And as you know, from hearing from Dr. Bagley, we have some very talented and accomplished researchers in our midst. So the Graken Center sits outside of any particular department within BMC, and we draw together experts and people interested in substance use disorder across BMC and Boston University. Probably our biggest two departments are really internal medicine, where folks like Colleen LaBelle, who I'm sure you've interacted with, and Jeffrey Samet work, Alex Wally and others, and also our Department of Psychiatry, which has a whole addiction psychiatry arm to it. So we draw together and help to coordinate and do quality improvement work with all of these different parts of BMC and Boston University. This slide shows the different clinical programs that are under our umbrella. Just running through them briefly from along the top row. We have Project Trust, which focuses on harm reduction, so distribution of sterile supplies, overdose prevention and intervention, education, prevention of infectious diseases, and working with people who have. Yeah, go ahead.
I'm sorry. Your slides don't seem to be working.
Oh, no.
We see the front one.
Oh, you're not seeing the additional slides. Jeez.
Correct.
What a day. Let me try again. Is that, are you seeing a different slide now?
Now it's different. Now we're seeing slide 4 of slide 8.
There we go.
Okay, and I just got another.
I think if you started and put it in slideshow mode from the beginning, we should be able to see it.
Are you able to see now my first slide?
No.
No, okay. Let me try unsharing again. I may just have to do this by voice because it's really kind of a mess. So why don't I try and you're not seeing any sharing right now? Okay, let me try one more time. Okay, you're seeing a slide now?
We see the first slide.
Okay, and how about now? Do you see a picture of me?
Yes, we do.
All right, so that's me. All
Great.
right, I'll keep. We'll try it. See if I can get any further.
Thank
So
you.
this was the graphic around all the different departments within BMC and BU that are under the Graken umbrella. And this is a graphic showing our various different programs. So upper left, harm reduction through Project Trust. We have a longstanding program called Project Assert that connects patients who come into our emergency department with treatment programs. And then Rapid Access is a recovery coaching program. So we have recovery coaches who are specifically focused on working with people when they're unstable with regard to their substance use disorder, helping to sort of take them by the hand and help get them connected with treatment. This is particularly important for BIPOC patients because we know that both nationally and within our own institution, patients of color are less likely to get treatment for their substance use disorder. So we have a special emphasis on trying to provide navigation services to make sure that they have the opportunity to connect with care. Project Respect is our well-known program focused on pregnant people with substance use disorder, working with patients from the time of knowing that they're pregnant through up to 2 years after delivery. And they do a tremendous job. And then so far, as a sort of paired program with Project Respect that focuses on working with parents who have young children who have where one of the parents has a substance use disorder. So often families move from Project Respect into the SOFAR program, and they can stay engaged with SOFAR long term. They have wonderful interventions such as a parenting intervention that teaches parents to understand verbal cues and physical cues of infants and helps have them to develop connection and empathy with the baby. And they're very successful at supporting families and helping with family reunification and families where an infant has been removed from the parent's care. OBAT, run by Colleen LaBelle, is our well-known primary care program where we care for over 1,000 patients with substance use disorder who are on medication treatment, and they're receiving primary care integrated with treatment for their substance use disorder. The addiction consult service was one of the first provides. It's our busiest consult service in the hospital. So they see a lot of patients with substance use disorders while they're inpatient. Down at the bottom, Faster Paths is our bridge clinic that provides same-day walk-in access to treatment and then connection to ongoing care. Catalyst, you just heard about from Dr. Bagley. START is a very innovative clinic that's focused on people who have substance use, stimulant use disorders such as cocaine or methamphetamine. It, again, is one of the first in the country and is being disseminated now in other parts of Massachusetts and nationally. And then our psychiatry colleagues have an addiction psychiatry program that focuses in particularly on people who have co-occurring disorders. This very busy slide just helps me to remember to mention that, what I was talking about so far is under the left-hand column, addiction treatment. But at the Graken Center, we actually have 4 pillars of what we focus on: addiction treatment, education and training, research and evaluation, and policy and advocacy work. So in the addiction treatment arm on the left, I told you about some of our addiction treatment programs. We also, a little over a year ago, started the Brockton Behavioral Health Hospital that has inpatient psychiatric care run by BMC and also a rehab program, a CSS program. We also provide support for data monitoring to do quality improvement and integration across addiction treatment programs within BMC and to connect with programs outside of our hospital. Under the education and training, we run a medical fellowship. Shortly after I arrived, we established a first in the nation addiction nursing fellowship, which is really important because our nurses are in a position to play a huge role working with patients, both in the inpatient and outpatient setting, to help to address their substance use disorders. We produce every 2 months a newsletter on the top addiction focused research papers that have been published in the preceding 2 months and have brief, rigorous evidence-based reviews of those as a tool to try to help primary care providers learn and understand how to treat substance use disorder. The Graken TTA, or Training and Technical Assistance, is a huge venture of its own. It's kind of our training and technical assistance arm, but it was established before the Graken Center was established and previously was known as OBAT TTA, and provides fantastic in-person and web-based trainings on addiction that is utilized by providers now across the world, across the United States for sure, but across the world in many different countries now are accessing that. We also have a variety of workforce initiatives to train particularly social workers in addiction-focused work, and several initiatives to bring young people of color into the workforce because they are under workforce, and it's a really important to diversify our treatment teams. Research and evaluation, many different programs. The one that I personally lead that I'm very excited about is the SUD and Anti-Racism Initiative. We have a multi-year project going on, community engaged research to understand how to improve addiction treatment for Black people to make it more appealing, effective, and equitable to help to engage more Black people who have substance use disorders in treatment. And then we also have under our umbrella highly regarded peer-reviewed addiction research and clinical practice journal called Addiction Science and Clinical Practice. On the advocacy and policy front, each year we set priorities for what we're going to work on that year. Overdose prevention centers has been at the top of our list for the last couple of years, really involved in the Massachusetts for Overdose Prevention group that is pushing to try to get legislation through our current current legislative session, doing a lot of work individually with legislators and getting the word out with op-eds. Our recent success has been around engaging with multiple unions who have signed on to endorsing overdose prevention centers. We also work with legislators and regulators and provide a lot of testimony and expert support related to addiction for various different types of policy and legal initiatives, and collaborate with a lot of community organizations and organizers on those issues as well. Wanted to briefly mention, I don't know if any of you attended the Boston Addiction Conference called Together for Hope. It happened very recently and was something that we worked on for over a year. We held the conference at Roxbury Community College and brought together many, many institutions, and both academic institutions and community-based organizations in Boston, and also people with lived experience of substance use disorder and their families. So it was held for 2 days, and we sold out both days with 530 slots each day. We also had opportunity to present research and clinical innovations. So we had presented 100 different abstracts and posters of that type of work. It was a really, really exciting conference and a huge amount of work, I must say. A lot of the plenary sessions were panels, as you can see on the upper right. And then we had some really fantastic keynote speakers like Commissioner of Health Goldstein, Dr. Basola Ojikutu, who leads the Boston Public Health Commission, and Kiame Mahania, a physician who is the Assistant Secretary of Health for Department of Public Health, Department of Health here in Massachusetts. We also had a huge exhibit hall where we had exhibitors, poster presentations, and space for people to mingle and collaborate. And then in addition to the main sessions of speakers and panels, we had 40 breakout sessions, which were smaller group sessions where people could learn specific skills. Here's Kenny Washington from the Boston Public Health Commission teaching harm reduction techniques, teaching the teachers of harm reduction techniques what's involved in harm reduction and how to provide harm reduction education and support. I went into a little bit of detail on this last bit because I wanted to mention that we are planning to take this statewide, and we're planning to do we're aiming for next spring, and we're planning to hold that tentatively, at least in Worcester. So would love to invite you all to engage with that and help suggest content that you think would be interesting, and potentially present the work of your organization there if you're interested. And that's the end of my comments.
Thank you, Doctor. Questions, comments? Just keep an eye on puts things in the chat too, if you need to. All right. Thank you, Doctor. Thank you for being with us, and thank you for that work. It is really an amazing breadth of work, and we're grateful.
Great. Well, thanks for inviting me to present. I appreciate it.
Thank you. Thank you. All right. We had hoped to have Ashley Witz with us today to talk about the Matador program, but she was not able to be here, so we will reschedule her. I remind people, if there are things that you're seeing out there, like the changes in the prenatal policy or other issues, just let us know that. And we are happy to incorporate that into the agenda. Anybody have anything they want to share with people? Upcoming events, programs, things you need, things you wish you had? I can only take certain areas, but whatever else you'd wish to have. All right. Well, thank you.